Ahora quiero presentarles al doctor José María Ferrer, también conocido como Jojo Ferrer. Él es doctor en medicina por la University of the Philippines, Philippine General Hospital. Tiene una especialidad en medicina familiar y, bueno, está muy involucrado con la American Heart Association, colabora con el Emergency Cardiovascular Care, que es una porción de la AHA, y con el ILCOR, que es el International Liaison Committee on Resuscitation. Colabora en la revisión de las guías y las recomendaciones científicas, el material educativo, desde salvacorazones, BLS, ACLS, ACLS-IP y PALS. Y es el editor del Science News and Cardiovascular Dailies, AHA's Electronic News Platforms for its professional members. Entonces, pues cerramos con broche de oro con uno de los ponentes más expertos en justamente la revisión, y quiero pedirles un fuerte aplauso para recibir al doctor José María Ferrer.
Bueno, muchas gracias, Rafa. Buenas tardes a todos. Y primero, muchísimas gracias a RCP para Vivir, a Jorge y Ernesto, a Rafa y todos los miembros del comité. Es un gran placer para mí para estar aquí. Bueno. Como Rafa ha dicho, soy José María Ferrer, pero todos mis amigos me llaman Jojo. Soy asesor de la ciencia y medicina en los programas de ACE, de la American Heart Association. Bueno, ahorita hacemos una cosa un poco diferente, pero muy interesante. Porque mi español no es perfecto, yo voy a hablar en inglés, pero la mayoría de mi PowerPoint es en español. Oh, okay. All right, so you guys know about ILCOR. ILCOR es la conglomeración global de los consejos de reanimación all the world, right? So we have 7 resuscitation councils. Mexico is represented by la FIC, la Fundación Interamericana de la Corazón. So what happens is ILCOR reviews the scientific literature for resuscitation continuously, not just every 5 years like some people say, but continuously. And then out of this review, ILCOR creates a document called the Consensus on Science with Treatment Recommendations. And I was fortunate enough to be part of this group. And then from this document, all the different scientific councils, the different national councils would create their own guidelines. Por ejemplo, la AHA, we created the guidelines for AHA, which is being used in both the US and in Canada. And again, I was fortunate enough to be part of that group. And we'll be talking about today the changes in the guidelines. The one major change in the guidelines is that no es una revisión entera. It's only an update. So this one is an update to the 2010 guidelines, and we only updated the recommendations that ILCOR reviewed over the last 5 years. There's been a lot of progress and a lot of publications since 2010. For example, this is a graph from Seattle, King County in Washington State in the US. You can see that their survival rate for ventricular fibrillation cardiac arrest is just way up there. This is old data actually, so they actually have higher survival rates at this time around, but 62% as of 2013, really high. So we were trying to find out what they were doing differently so that we could apply those best practices in other areas of the US. In 2012, the AHA also published a statement on dispatch-assisted CPR. And this actually formed a lot of science that now makes it into the recommendations for 2015. We also published in 2013 a statement on CPR quality. And this one was a consensus amongst different experts, but they looked at different things that comprise high-quality CPR, like chest compression rate, chest compression depth. And a lot more research has been done since then that made it into the 2015 guidelines. So, what are the hot topics for 2015? Not in any particular order. The bigger changes for the 2015 guidelines update are listed here. Las sistemas de cuidado. So it's now es una nuevo capítulo en las guías 2015. We now talk about the use of social media, and you heard it in Tom's talk. You also heard it in Dan's talk earlier, that people use smartphone apps like PulsePoint to really try to get more bystanders to do CPR. So that's really a big thing, not only in the US, but around the world as well. We continue to focus on CPR quality, especially on identifying what the best chest compression rate and chest compression depth is. We also, new to the 2015 guidelines, we talk about the administration of naloxone or Narcan for opioid-induced respiratory arrest or cardiac arrest. We talk about devices during CPR, and Dr. Timmerman talked about that this morning as well. We now have a new term for therapeutic hypothermia. We now call it targeted temperature management because it's no longer about just making the patient cool, and I'll talk about that later on. And this is a change that actually spans across the different ages, not just adults, but also kids. And then finally, in the field of education, we talk about retraining intervals. So the new recommendations from the new systems of care chapter, we now have 2 chains of survival. So hay dos cadena de supervivencia. One for in-hospital cardiac arrest and one for out-of-hospital cardiac arrest. And the important thing to note here is that for in-hospital, there's the element of surveillance and prevention, right? You can't really do that out of the hospital. But for in-hospital, that obviously can happen. So, you have patients in your ICU that are monitored, so you can actually see if they're deteriorating so that you can prevent the cardiac arrest before it even happens. The out-of-hospital chain of survival is pretty much similar to what it was in 2010. Again, so we talked about this, smartphone apps that are used to summon rescuers. This is a screenshot of a PulsePoint app. I actually have it on my phone as well. So the concept is if someone has a cardiac arrest right in your vicinity, even if you don't know, if someone calls 911 and then that gets to the dispatcher will then use technology to get push notifications to your cell phone so that you can then go there and help out. Okay, so what I'm doing here is something different as well. So normally this lecture is really just going over the guidelines changes. I wanted to change it a little bit because it's the end of a long day, and I know that a lot of you have heard about these in the last 3 days. So yo espero que esto es una revista solamente para ti. So it's like a review of all the recommendations that we've seen in the last 3 days. So this one I would like to, so this I got from the internet. So you see the 2 blogs there. This is really our end user telling us what the guidelines mean to them, right? So what to them would be the highlights of the guidelines, and our end users, the people who actually created these infographic, they're emergency medicine physicians, they're paramedics. So like again, these are the people who are actually using the guidelines, people like you. So we tried to focus on just those big changes, the top 5 changes to CPR, and all of you know about this, you've heard about this this last few days. Compression rate, 100 to 120. In 2010, it was just at least 100. For 2015, we now put an upper limit, 120. And this is because studies have shown that if you go faster than 120 compressions per minute, patient outcomes, the survival actually goes down, it decreases. So the sweet spot is somewhere like 110, 100 to 120. And then similar to what we said in 2010, minimize compression time, right? Keep your interruptions to 10 seconds or less, or better yet, keep your chest compression fraction to higher than 60%, 80% if you can do it. And I'll talk about that in a couple of slides down. Chest compression depth, we know about at least 2 inches in 2010. Now we put an upper limit of 2.4 inches. So the sweet spot for chest compression depth is 5 to 6 centimeters, right? We'll talk about more of that right now. Bueno, chest compression rate, la frecuencia de las compresiones torácicas. So like I said, 100 to 120, easy to remember across the board. Children, adults, all the same. We also did something different. Now you can actually do both pulse check and ventilation check at the same time, right? Before it was like strictly like if you did your course, you had to do like a breathing check before and then a pulse check after. Actually, in clinical life, and the way I would do it, while you have your fingers on the pulse, you're actually checking for breathing as well. So it only makes sense to allow this flexibility to our providers, right? Now, how about people who have difficulty checking a pulse? Then we say, then you can still do it separately. But now it's more flexible. You can do either or. Again, try to minimize interruption to chest compressions. The studies have shown that if you get to at least 60%, right, which means of your total code time, 60% of that is actually hands-on time, hands-on the chest time. If you do that, actually if you're higher than 60%, because we've shown that using the pit crew approach, using high-performance CPR, you can actually get to numbers as high as 80%, which means like in a 10-minute code, for example, 8 minutes of the time, you are on the victim's chest. Okay, so here's the controversial one, la profundidad de las compresiones. So this was out of a study that showed that there were more injuries above 6 centimeters, right? So this is what we tell them. If you have a feedback device that tells you how deep you actually are, then you could do this. You can use this in training, where it actually has more research. You can also do this in real clinical practice, even though there's really not much science there for now. However, because we know that the problem of healthcare providers is that they tend to press more shallow than deep, right? So we tell them, if you don't have any feedback devices, or if you can't really do 5 to 6 centimeters, just make sure you're compressing deep, right? So push hard, push fast. That is still the message that we want to tell people. Because we don't want people thinking twice and then going too shallow. That would be a big disservice to our patients. And again, here's just like a slide that shows you the different depths of compression across the different age ranges. For kids, para los niños, 5 centimeters. Infants, 4 centimeters. Puberty and above would be considered an adult, so that would be 5 centimeters or 2 pulgadas. What about leaning or complete chest recoil? Similar to what we said in 2010, right? It hasn't really changed. We tell them not to lean between compressions and to make sure that you actually have the chest come to a complete or full recoil, because we want the blood flowing back into the heart. So all of these really are just the different components of high-quality CPR, things that you've already known since 2010 or even earlier. The other big changes for CPR, directive dispatchers. So this, like Tom said, you call 911, the dispatchers would ask you 2 questions. Is the patient responsive? Is the patient breathing normally? If you get no to those 2 questions, start giving CPR instructions to that bystander. Audiovisual feedback, if you have it, use it. That's it for CPR, right? And again, just a reiteration of the emphasis on the high quality CPR. We need to remember that la fundación of life support, right? The soporte vital is basic life support. Y la fundación del soporte vital básico es los compresiones de alta calidad. Really, that's it. High quality chest compressions. That's the very basic. BLS. So now we introduce naloxone, a new drug that we give for people we suspect have had opioid overdose. And then we couple that with some education. So we tell those particular people, as well as the family members around them, that if something happens, if that patient goes into respiratory or cardiac arrest, that they could give naloxone. So this is really new in the US. It's not practiced across all the different states yet, but there are states where you can just buy naloxone over the counter that a lay provider can then give. I'm not sure how big of a problem opioid overdose is here in Mexico, but in the US it is a big problem, which really prompted the AHA to look at this issue and then make this recommendation. And then this is a first aid recommendation. We no longer recommend the use of collars, right? In fact, that's a class 3 recommendation. So if you have suspected spinal cord injuries, all you need to do would be to manually immobilize the spine with your hands. That's it. It's as simple as that. The one thing that we remember from the guidelines update, the guidelines recommendations, is that things are becoming simpler along the years, right? If you remember like 15, 20 years ago, ACLS was really hard. Now it's actually gotten easier and more simple. Because now we realize that the things that really affect patient outcomes are the things that we have known for a while to be really foundational. Like I said, chest compressions, right? Breaths for people who need it. Those kinds of things. Minimal interruptions. So these are the recommendations for the treatment of opioid overdose that leads to arrest. So you could give naloxone either intranasally or intramuscularly. There's also an IV dose actually for healthcare providers. So what do we say? Like if you come across a person who's in arrest and you know that that person may be a victim of opioid overdose, we can do this. However, you should not delay the giving of basic life support. Right? That's foundational. This should not delay or access to emergency medical service. If you need time to retrieve the naloxone and you're leaving the patient by himself, then don't do it. We actually have a new algorithm for naloxone treatment in respiratory and cardiac arrest. Bueno, the top 5 changes for ACLS. Number 1, vasopressin is out. Number 2, we can now use ultrasound for confirmation of endotracheal tube placement. Number 3, if you find a shockable rhythm, give epinephrine as soon as possible. Okay, so let's go into to each one in greater detail. So the studies have shown that vasopressin, whether by itself or in combination with epinephrine, really does not offer any significant advantage or benefit over epinephrine alone using standard dose. So for that reason, right, and especially because we're looking at the effect to patient outcomes, so neurologically intact survival, if it really doesn't affect that, then we actually don't need it. So to make it simpler, por simplificación, la vasoprina ha sido removida in the algorithm for 2015. What about epinephrine? And again, like I said, so you still give it. And if it's a non-shockable rhythm, you give it as soon as possible. If it's a shockable rhythm, it's still the same as the algorithm in 2010. You give epinephrine after the second shock. At least that's how it is in the algorithm, but obviously different institutions and agencies have their own protocols on when to give it. Tom actually mentioned this, use maximum oxygen during CPR, 100%. And then the moment you get the pulses back, then you dial it down. ECMO is also now a good alternative to CPR. So in institutions that have the resources, have the skill set, have the manpower to do ECMO or extracorporeal CPR, then we say do it. We'll talk about that in more detail a couple of slides from, actually here in this slide. See, so if you have the resources to do RCP extracorporea, then yes. It's actually been shown to be really, really beneficial. However, remember that it takes time. The providers need to know how to do it. They need to be trained on it. And obviously, there's money involved because you need to buy those resources. So this is actually going to be one of those future principles of CPR that we'll be talking about for years to come. Post-arrest care. Number one, very easy. We focus on the ABCs again. No hyperoxygenation. We try to keep it between 94 to 99%. Try to keep the ETCO2 30 to 40. And then you see there the mean arterial pressure of greater than 65. Number two, so this is the big change for post-cardiac arrest in 2015, right? Like I said, we no longer call it therapeutic hypothermia. It's now TTM, targeted temperature management. And I'll talk about that after this slide. Number three, big change. If you get ROSC and there's ST elevation, then take that patient to the cath lab. And even if you don't see ST segment elevation, but you suspect like a cardiac etiology, maybe presumably an obstruction, obviously that patient also needs to be taken to the cath lab as soon as possible. So here we go, TTM, right? Targeted temperature management, manejo específico de la temperatura. So in 2010, if I'm not mistaken, we said 32 to 34 for at least 12 to 24 hours. Now there's more research that shows that the best range for targeted temperature management is anywhere between 32 to 36, right? But what does that mean? That means that you'll actually have to choose. You pick a temperature in that range. For example, you pick 34, and then you maintain that for at least 24 hours. It is important to remember that there should be no active rewarming. So if the patient comes in and the patient's temperature is, let's say, 33, then try not to choose a temperature that's higher. You can choose 33, just keep the patient at 33 degrees, or lower that to 32. So actually, this intervention has been one that really shows good benefit in terms of neurologically intact survival. Now, what about pre-hospital cooling? I'm not sure if you guys do it here, but in the States, before the big study came out 4 years ago, they would do pre-hospital cooling in ambulances, as the patient is being transported to the hospital. What the research showed is that if you're doing pre-hospital cooling with cold IV fluids, there is no benefit to outcomes. So we say don't do it. Now, if you have other means of doing cooling outside the hospital, then it's still worth doing the research so that we'll have more information, and then we can give a recommendation about that. But for now, if you're using cold IV fluids for pre-hospital cooling, that's no longer recommended. Wait before you prognosticate. 72 hours, something to remember. And 72 hours after TTM, if the patient undergoes that. Anytime before that, you can't really prognosticate. The patient may still have have good outcomes, right? But you can't see that before 72 hours. So it's important to wait before you determine the patient's fate. Number 5 is pretty self-explanatory. For patients that we can't really save, there's the option of organ donation. So we need to consider that when we withdraw care. What about PALS? Para los niños. So the top 5 changes. Fluids and sepsis, and we'll go over that in detail. It's no longer necessary to use atropine routinely as pre-medication for intubation. But if you are going to use it, there's no minimum atropine dose now. Okay, so in detail. Recomendaciones para la reanimación con líquidos. So an initial bolus of 20 milliliters per kilo is still okay, but it's important to constantly reassess the patient, right? I think that's pretty, that's just like good clinical practice. Whenever you give an intervention, you make sure that you reassess. And then you can repeat it if necessary. There's actually no evidence that giving pre-medication, atropine as pre-medication for intubation is helpful. So it's no longer recommended. However, if the patient is still at risk for bradycardia, then you can consider it. So this is the targeted temperature management version for kids. Avoid fever at all costs. And then the fifth top change is now you can use either amiodarone or lidocaine as your antiarrhythmic of choice. Again, in more detail. So for children who are comatose, in the first several days after cardiac arrest, so there's actually a protocol that we need to use. So it's not 32 to 36, at least 24 like in the adults. It's more specific for kids, right? So you have two options. One is that you choose between a temperature of 36 to 37.5 for 5 days, or 2 days of hypothermia at 32 to 34, followed by 3 days of normothermia. So people would ask me, why is this protocol this way, right? Like, where did you get the numbers from? Well, the studies where this was done, these are the protocols they use. So there's no reason for us to use another set of range of temperatures, right? So we really base it on the research. And again, lidocaine and amiodarone, right? So for kids, they're now on equal footing. So we've reflected this in the algorithm. In the algorithm, you can see that you can give either amiodarona or lidocaine. So it's both are either okay, both are okay. Special situations, resuscitation. So if any of you have taken ACLS EP, or if any of you are instructors of ACLS for experienced providers, these changes will make it to that course. Number one, we have new recommendations for pregnant women who are in cardiac arrest. Number two would be the same. That's also a recommendation for cardiac arrest in pregnancy. Number three is a recommendation on using thrombolysis and thrombectomy for pulmonary embolism. We won't discuss that too much, but I just wanted you guys to be aware of that. But in more detail, for the cardiac arrest in pregnancy, again, high quality CPR, number one, right? And then we'll have to consider that you can do left manual uterine displacement to relieve pressure as you're doing compressions. Now, what about emergency cesarean section? What we say in the recommendations, based on consensus and based on science, is that after 4 minutes of cardiac arrest or after 4 minutes of resuscitation attempt, if you're still not getting ROSC or return of spontaneous circulation, then you would consider doing an emergency cesarean section at 4 minutes time. And again, this is important to note that you really need to think about both patients, right? Both the mother and the kid. So which is why, with all those considerations, this recommendation was made. Toxicology. Now we have a new recommendation for using intravenous lipids. And again, number 5, we've already talked about it, the use of naloxone for opioid overdose. More on number 4 here. So you can consider giving IV emulsion of lipids if you're looking at toxicity caused by local anesthetics, for example, or other similar toxicities. Again, this is like higher level ACLS EP stuff. We're almost there. So resuscitation education. I just wanted you guys to read this. I don't actually have Spanish slides for this. But we're getting more studies for resuscitation education, and some of it is based on research from other fields of medicine, and some of it is just based on the field of education in general. We already know this, but high-fidelity mannequins for ACLS, they're actually beneficial in improving learning outcomes. And then we say that more BLS and AED instruction, you can do it self-directed, which is using a video, or using traditional instructor-led training. And obviously, more frequent retraining is helpful, right? So we used to have the every 2-year cycle. Every 2 years, you would need to get recertified and then get your card. What we found out that as soon as you leave the classroom, your skills, both cognitive and psychomotor, actually decrease, right? It's like buying a car. The moment you take it out of the dealership, the value goes down, right? So within a matter of weeks, I was kidding when I said like immediately after, but within a matter of weeks, those skills actually decay. They go down, they deteriorate. So if you do it every 2 years, what does that mean? There's actually a period of time that you're actually not at your best in terms of skill acquisition. So what we did at the AHA, for example, is we developed a program called RQI, Resuscitation Quality Improvement. So instead of every 2 years, we train the people every quarter, right? So every 3 months. And we found that doing that actually keeps their skills like pretty high. The moment it's ready to like decay, they're due for another module. Now, every quarter may not be the best timing. We don't know that yet, which is why we need more research. But we need to do all these different things so that we can then study them, and then hopefully those results feed back into the guidelines process. So it's like a virtuous circle of recommendation, and then implementation, and then more research, and then that leads to more recommendations, and then implementation and research. And I'm really trying to make a good point of that particular concept, because I know that we've discussed this, Jorge and I, and Rafa and I last night. This is something that we really want and need to happen to Mexico. Finally, changes number 4 and 5 for resuscitation education. Team and leadership training. So it's not enough that you train someone on how to do the interventions, but you also need to teach them how to be team leaders, how to be team members. I mean, right now, we've heard about pit crew CPR, high performance CPR. It's all about knowing what your role is in a particular team, right? A team is only as strong as its weakest link. So everyone in that team needs to know exactly what they're doing. There has to be choreography even. Like it's like a dance, or like Tom said, it's like a pit crew in NASCAR racing. Once the car comes in, people would know what to do. And let's not forget the people who are not healthcare providers, bystanders. The more that we can train people who are outside, our family members, our friends, the more that we're creating a generation of lifesavers. I actually do this on my spare time. I volunteer and I teach hands-only CPR, in churches and communities, and I urge you guys to do the same, because it's not only about us healthcare providers. Remember, the first people who encounter a cardiac arrest would most probably be like someone's mother or someone's brother or someone's sister, right? So those people need to know how to do CPR. So what now, right? So we've heard about all these new recommendations. They're not really big changes from 2010, but still, these recommendations are based on new research that have come out, right? So new and old research really forms these recommendations. And we know that the more research that comes in, it really pushes the field for improvement. For example, just a quick example. So we had a 2010 guidelines, we had 2015 guidelines. If you look at that trajectory, we're expecting guidelines in 2020, right? However, a couple of big studies have already come out this year and last year. You heard about the continuous chest compression study that was released last year, and then the ALP study that was released this year, just a few months ago. If we wait until 2020, that will be too late. So ILCOR, the AHA, and all those other resuscitation councils are trying to find a way where we review the evidence continuously. And then if the evidence is enough that it will change current recommendations or that it will change practice, then we write those recommendations and publish them, and then teach that to the end users, right? Basically people like you and me. However, this is not something that just happens in the UK or in the US or in Canada. Remember that cardiac arrest and other emergency cardiovascular conditions, that's a worldwide problem, right? It happens in Dallas, it happens in the Philippines, it happens in Mexico. So we need research from all over, right? Mexico included. Por ejemplo, ¿quién aquí sabe el índice de supervivencia de paro cardíaco en la Ciudad de México? En el país de México? We don't know. So how can we improve it, right? So you've heard this last line from a lot of people today and yesterday. We can't improve what we don't measure. No se puede mejorar lo que no se mide, right? So we need to start measuring. I mean, I really need people like you to think about research, hacer muchas investigaciones. You know, we need to publish more. Hay que colectar más datos. Hay que hacer estadísticas. I mean, really, this is all about you and me. So, hacemos un cambio y hacemos la diferencia. Gracias.